Most women over 60 have been told the same thing at every mammogram, at every annual physical, at every well-woman visit for decades. Check for a lump. That's the message. Find the lump. That's how you know. But here is what the research says that nobody is putting on those appointment reminder cards. Roughly 40% of breast cancer diagnoses in women over 60 do not begin with a lump. They begin with something else, something smaller, stranger, easier to dismiss, something that sounds, when you describe it to a doctor in a 10-minute visit, like nothing important. And because the lump message is so dominant, so deeply embedded in the way women have been taught to think about breast cancer, these other signs get explained away by physicians who are rushed, by women who do not want to be alarmists, by a medical culture that sometimes forgets how differently breast cancer can present in a body that has been through menopause. This video is about the 5 signs that women over 60 are most commonly told to ignore, or told to watch and see, when watching and seeing is exactly the wrong response. I'm Dr. Hayes Anderson, and after 22 years in senior health, I've seen firsthand how many women in their 60s and 70s arrive at a serious diagnosis, having mentioned a symptom months, sometimes over a year, before that diagnosis, and having been sent home with reassurance. By the end of this video, you will know all 5 signs, why each one is dismissed, what the medical evidence actually says about its significance, and precisely what words to use with your doctor if you are experiencing any of them. Stay with me, because sign number 4 is the one I hear about most often, and the one that almost never gets taken seriously until it's too late. Here is the knowledge gap that makes all 5 of these signs dangerous. After menopause, breast tissue changes. The dense glandular tissue that made up much of the breast during reproductive years gradually gives way to fattier tissue. Tumors in fatty tissue can feel and behave differently from tumors in dense tissue. They are more likely to be diffuse rather than sharply bordered. They are less likely to announce themselves as a firm, obvious mass. They are more likely to cause changes in the surrounding tissue, in the skin, in the nipple, in the shape or weight of the breast, before they produce anything that registers as a classic lump. This is biology, not bad luck. And it means that the single symptom, lump-focused education that most women have received is genuinely incomplete when applied to women over 60. The 5 signs I am about to describe are not rare findings from obscure case reports. They are documented presentations, recurring, identifiable, and consistently underreported in the clinical literature on breast cancer in older women. The first sign is persistent itching, redness, or a rash on the breast that does not respond to treatment. Skin changes on the breast are almost always explained as dermatitis, eczema, or an allergic reaction, and sometimes they are. But there is a specific subtype of breast cancer called Paget's disease of the breast that begins in the nipple and the areola and looks, for months and sometimes years, exactly like a skin rash. It produces itching, scaling, crusting, redness. It can produce a burning sensation. It may cause the nipple to flatten or invert. And because it looks like a skin condition, women are often sent to a dermatologist rather than a breast specialist, treated with topical creams, and told it will clear up. When it doesn't clear up, when the rash on the breast or nipple keeps returning despite treatment, that recurrence is a red flag that must be evaluated with a breast-focused workup, not another round of cortisone cream. Loretta, 67, had what her dermatologist called contact dermatitis on her left nipple for 14 months. It improved slightly with the prescription cream. It always came back. She was not alarmed because it did not hurt, and it did not look serious, and she had been told it was a skin thing. When she mentioned it at her annual mammogram, the technician flagged it. The subsequent evaluation found Paget's disease with an underlying ductal carcinoma. Had she been asked about skin changes earlier, had her first dermatologist considered the breast-specific differential, the timeline might have looked very different. Paget's disease accounts for roughly 1 to 3% of breast cancer diagnoses, a small number in absolute terms, but a significant one when the presentation is a chronic, treatment-resistant rash on the nipple or areola of a woman over 60. The second sign is a new difference in the way one breast feels heavy, full, or swollen, without a lump. This one is particularly difficult because the sensation is diffuse. There is no specific spot to point to. The breast just feels different, fuller on one side, heavier, occasionally tender in a way that is new and not explained by anything obvious. Women are told it is hormonal, even though they are postmenopausal. They are told it is weight gain. They are told one side can simply be larger. All of those things can be true. But a new asymmetric fullness or heaviness in a breast, particularly when it develops over weeks rather than being a long-standing feature, warrants imaging. The type of breast cancer most associated with this presentation is inflammatory breast cancer, which is both less common and more aggressive than most forms. Inflammatory breast cancer can progress rapidly and does not always produce a discrete lump. It causes the breast tissue to swell, to feel firm or tender, and to look warm or faintly red. The absence of a lump is not reassurance. It is actually one of the defining features of this diagnosis. The clinical guidance is clear. New unilateral swelling, heaviness, or warmth in the breast of a woman over 60 should be imaged and evaluated, not observed. The third sign is nipple discharge, particularly if it is bloody, comes from one breast only, or appears without any squeezing. Nipple discharge in postmenopausal women is not normal. This point cannot be stated strongly enough. Before menopause, nipple discharge can have many benign causes: hormonal fluctuation, certain medications, stimulation. After menopause, the hormonal environment that drove those benign causes is gone. Any nipple discharge in a postmenopausal woman should be evaluated. Full stop. The discharge that most warrants urgent attention is bloody or blood-tinged discharge. Discharge that comes from a single duct opening rather than multiple openings, and discharge that appears spontaneously, without compression of the breast. These features together, and particularly bloody spontaneous discharge from one side, are associated with intraductal lesions, including papillomas and ductal carcinoma in situ. Many of these lesions are early stage and highly treatable. The danger lies in the explanation. Women are told it is probably nothing. They are told to stop pressing on the breast and see if it resolves. They wait, sometimes for many months. The correct response is a referral for ductography or breast MRI, not watchful waiting without imaging. Stay with me, because the fourth sign is the one I hear about most consistently, the one women mention almost as an afterthought, and the one that routinely gets dismissed with the least investigation. The fourth sign is a change in the shape, contour, or skin texture of the breast, dimpling, puckering, or an area where the skin looks thickened or different, like the surface of an orange peel. This description, skin that looks like the peel of an orange, has a medical name, peau d'orange, and it is a recognized sign of inflammatory breast cancer and other aggressive presentations. What causes it is lymphatic obstruction beneath the skin. The cancer blocks the small lymphatic channels that drain the breast tissue, and the fluid backs up, causing the skin to develop a dimpled, thickened, stippled texture. Women notice it. They notice it in the mirror, in the shower, in the way a particular spot looks different in certain light. and they are told, often by doctors, often more than once, that it is aging, that skin changes as we get older, that the tissue redistributes after menopause. It can look subtle. It is easy to doubt your own eyes. Winifred, 72, noticed an area on the underside of her left breast, near the fold, where the skin had started to look different. Not dramatic, just not quite smooth the way it had always been. She described it to her doctor at her annual visit. He examined her, found no lump, and told her to monitor it and come back if it changed significantly. She came back 4 months later. The texture had spread. The breast had started to feel heavy. The diagnosis was inflammatory breast cancer, stage 3B. The 4 months between her first mention of the sign and her second visit did not have to exist. Dimpling, puckering, or orange peel texture on any part of the breast, even a small area, even subtle, should prompt imaging, not a watch and wait recommendation. The fifth sign is pain. Specifically, new, persistent, localized breast pain in a postmenopausal woman. Pain that is in one spot, stays in one spot, and does not fluctuate with activity or time of day. Breast pain is the sign most aggressively dismissed. Physicians are taught early in training that breast cancer is almost never painful, and for the majority of presentations that is true. But almost never is not never. A subset of breast cancers, particularly certain locally advanced presentations, do produce pain. And the pain associated with cancer has a distinct quality. It is localized rather than diffuse. It is persistent rather than intermittent. It does not worsen with exercise and improve with rest. And it does not follow the cyclical pattern that benign breast pain tends to follow. Postmenopausal women do not experience the hormonal cycling that drives the most common forms of benign breast pain. When a woman who has not had breast pain for years develops new, localized pain in one area of the breast that persists for more than a few weeks, that pattern deserves imaging, not reassurance that breast cancer doesn't hurt. Sandra, 64, had a dull, persistent ache in the upper outer quadrant of her right breast for 3 months before she mentioned it to her physician. She had not mentioned it sooner because she had been told her whole life that breast cancer doesn't cause pain, and she did not want to waste anyone's time. When she did mention it, she was told it was likely musculoskeletal, a pulled muscle perhaps from gardening. She was told to take ibuprofen and see if it resolved. It did not resolve. When she pushed for imaging 6 weeks later, the ultrasound found a 2-centimeter mass. None of these 5 signs are exotic. None of them require specialized knowledge to notice. What they require is the confidence to report them, the persistence to ask for imaging when reassurance is offered instead, and the understanding that breast cancer in women over 60 does not always follow the single-story script of finding a lump. Here is the truth at the center of this. You are the expert on your own body. You know what your breast has felt like and looked like for 60, 70 years. When something is new, that matters. Your perception of change is clinically meaningful, even when it cannot be pointed to on an exam table, even when a doctor says it is probably nothing. Do not accept probably nothing without imaging. Probably nothing is a clinical opinion. An ultrasound or MRI is clinical evidence. You are entitled to the evidence. Here is what I want you to do if any of the 5 signs I described today apply to you, now or in the past or as you watch this. Write it down. Every detail you can remember about when it started, how it looks or feels, whether it has changed. Then make the appointment, and when you go, use these exact words. I would like to be referred for breast imaging, not just a physical exam, because I understand that clinical signs in postmenopausal women can be missed on exam alone. That sentence is your right to say. Say it. And speaking of silent biological processes that shape the outcome of conditions like cancer, the next video in this series goes deep into chronic inflammation. It is one of the most consistently identified factors in the environment that allows cancer cells to take hold and proliferate. And yet most people have never been given a clear, practical explanation of what it is, how to know if they are running it, and what can measurably lower it. That video is coming very soon. Do not miss it. Before I go, I want to hear from you. Drop your answer in the comments. Have you ever mentioned a breast symptom to a doctor and been told to wait and see? And what happened next? Your answer could be the reason another woman watching this finally makes her appointment. And if this video matters to you, share it with your daughter, with your sister, with a friend who has been brushing something off. That share may matter more than you know.